Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, the neuro-intensive care and critical care neurology. Neuro-intensive care and critical neurology. I'm going to cover almost all the important concepts of neuro-intensive care and critical care neurology like cerebral edema, herniation, the monro-kellie hypothesis, intracranial pressure and its relationship to cerebral perfusion pressure, mean arterial pressure and autoregulation. So almost all the important concepts of neuro-intensive care and critical care neurology I would be covering up in this one lecture. And I feel this lecture is going to be useful to physicians, neurophysicians, neurosurgeons, anesthetists, neuroanesthetists and intensivists. And definitely it's going to be useful to all the MBBS graduates, physiotherapists, nursing and dental students. So now let's move on to the topic, the neuro-intensive care and critical care neurology. The neurology critical care focuses on preservation of neural tissue and prevention of secondary brain injury caused by ischemia, hemorrhage, edema, herniation and elevated intracranial pressure. Cerebral edema. Cerebral edema is swelling of the brain with an increase in brain volume due to an increased water content. Edema can lead to increased intracranial pressure. And intracranial pressure and increased in the intracranial pressure can cause herniation and injury by mechanical distension and compression in addition to the ischemia of impaired perfusion consequent to the elevated intracranial pressure. So what are the types and pathogenesis of cerebral edema? Basically, we have vasogenic edema, cytotoxic edema, osmotic edema and interstitial edema. Cytotoxic edema. It is due to the disruption of the tight junctions that make up the blood-brain barrier, causing an increase in extracellular fluid volume due to an increase in capillary permeability. So we have the tight endothelial junctions of the capillaries on one side and the brain on the other side. When these tight endothelial junctions are broken down, when the blood-brain barrier is disrupted, the water content in the intravascular compartment goes into the extravascular compartment and the neural tissue, causing edema. This is known as vasogenic edema. So it is due to the disruption of the tight junctions that make up the blood-brain barrier, causing an increase in the extracellular fluid volume due to an increase in capillary permeability. The fluid contains proteins and collects primarily in the white matter. It primarily occurs with a focal mass lesion such as neoplasm or abscess. So this is vasogenic edema. The next edema what we see in the clinical practice very common is the cytotoxic edema, especially in the ischemia of the brain. So what is cytotoxic edema? There is an increase in the intracellular fluid volume due to a failure of the energy dependent mechanisms that normally keep water from entering the cell. So because of the failure of the energy dependent mechanisms, the fluid enters the cell. Cytotoxic edema, the blood-brain barrier remains intact unlike the vasogenic edema where the blood-brain barrier is disrupted. Because of the increased water inside the cell, the neurons, glia and capillary endothelial cells in both gray and white matter imbibe water and swell. So there's a big amount of swelling because of neurons, glia and capillary endothelial cells which imbibe water and swell. It occurs basically when the brain suffers damage due to hypoxia, ischemia or other metabolic abnormalities such as uremia. In stroke patients, especially ischemic stroke, the cytotoxic edema is very common because of the failure of the energy dependent mechanisms. So cytotoxic edema after stroke occurs 24 to 72 hours after the event. So some of the stroke patients apparently recover, but after 24 to 72 hours again they deteriorate. It is because of the cytotoxic edema and increase in the intracranial volume because of the cytotoxic edema. The third type of edema what we see is the osmotic edema. This occurs when there is high hemodilution, as in inappropriate antidiuretic hormone secretion or rapid reduction in the blood glucose in the hyperosmolar hyperglycemic state. So what happens here? The brain osmolality then exceeds serum osmolality and water flows into the brain along the abnormal pressure gradient, causing edema. So osmotic edema is because of the osmotic difference between the brain and the blood, and therefore the fluid starts entering from the blood and enters into the brain. This is osmotic edema. We see this in hyperglycemic states when we try to correct it. Interstitial edema. Here there is an increase in extracellular fluid volume that occurs in the periventricular white matter because of the transependymal transduction of CSF through the ventricular wall when the intraventricular pressure is increased. So when the intraventricular pressure is increased, the fluid just sweeps from the intraventricular space into the interstitium. So this is known as interstitial edema. Both vasogenic edema and interstitial edema primarily affect the white matter. The fluid in the interstitial edema, however, contains little protein. So summarizing the various types of cerebral edema, because it's very important, especially when we treat patients in intensive care unit, the critical patients. So we have vasogenic edema. It is because of the disruption of the tight junctions in the blood-brain barrier. Cytotoxic edema basically we see in hypoxic and ischemic conditions of the brain, where there's an increase in the intracellular fluid volume due to a failure of the energy dependent mechanisms that normally keep water from entering the cell. We have osmotic edema occurs in conditions with hemodilution. Brain osmolality then exceeds serum osmolality and water flows into the brain along the abnormal pressure gradient, causing edema. And finally we have interstitial edema, which is because of an increase in the extracellular fluid volume that occurs in the periventricular white matter because of the transependymal translation of CSF through the ventricular wall when the intraventricular pressure is increased. Right. Having understood the basic concepts of cerebral edema, now let's focus our attention to ischemic cascade and cellular injury. Ischemic cascade. When delivery of substrates, principally oxygen and glucose, brain and neurons, cerebral neurons depend so much on oxygen and glucose for its survival. And therefore, when the delivery of substrates, principally oxygen and glucose, is inadequate to sustain cellular function, a series of interrelated biochemical reactions known as the ischemic cascade is initiated with release of glutamate, a neuroexcitatory substance, and influx of calcium, which leads to cytotoxic edema. We need to understand another important concept, the ischemic penumbra and the secondary brain insults. What is the ischemic penumbra? It refers to areas of ischemic brain tissue that have not yet undergone irreversible infarction, implying that these regions are potentially salvageable if ischemia can be reversed. Generally, when there is ischemia to the brain, there are three regions appearing adjacent to each other. One, the central core area, which is infarct, cerebral infarct. The death of the tissue has already occurred. Surrounding the infarct tissue, we have the ischemic penumbra, where there is decreased blood flow, but still the brain has not undergone a death. So there's no infarction, it is only ischemia, and this can be salvageable with appropriate treatment. And finally, beyond the ischemic penumbra, we have the normal brain tissue where there's a good amount of oxygen supply. So ischemic penumbra is the middle layer wherein there's a deficient of oxygen, but still the tissues are in a reversible state where it can be brought back to normalcy if immediately oxygen is restored. So ischemic penumbra refers to the area of ischemic brain tissue that have not yet undergone irreversible infarction, implying that these regions are potentially salvageable if ischemia can be reversed. Another important concept is secondary brain insults. So the primary insult may be ischemia, hemorrhage, or head injury. But what are the secondary brain insults? Factors which reduce substrate delivery, like systemic hypotension, wherein the systemic blood pressure falls, or hypoxemia, where the saturation of oxygen goes down, or factors which increase cellular metabolism, like fever, seizures, and hyperglycemia, which increase cellular metabolism. So prevention, identification, and treatment of secondary brain insults are fundamental goals of management. Yeah, now I'm going to talk about a very, very important concept, the intracranial pressure, the increased intracranial pressure, especially the monro-kellie hypothesis. Monro-kellie hypothesis. According to this hypothesis, the intracranial cavity is a closed space. 3 compartments occupy this space: blood about 75 ml, brain about 1400 ml, and CSF about 75 ml. Because there's an overlying skull bone, the brain cannot expand when there is a when there's an increase in any of these 3 compartments. So because the cranium cannot expand and the brain cannot be significantly compressed, when the volume of one of the compartment increases, the volume in other compartments must undergo a compensatory decrease. If this compensation fails, then the intracranial pressure increases. Therefore, significant increases in volume eventually results in increased ICP. Because the overlying skull bone is there, when there is an increase in any of these 3 contents, be it brain or blood or CSF, especially brain, it cannot expand because there's an overlying skull. So the other 2 components should decrease in their capacity. Initially it happens when the CSF goes from the intracranial compartment to the spinal canal, which we call it as a compensatory phase. But then beyond which, when it cannot go beyond the compensation, a decompensated phase occurs wherein the brain can't expand further because the overlying skull. So the pressure inside the brain increases, what we call as a raised intracranial pressure. So this is monro-kellie hypothesis. So the intracranial cavity is a closed space and the 3 compartments occupy the space: blood 75 ml, brain 1400 ml, and CSF 75 ml. Very important. That's why to decrease the intracranial pressure, sometimes we take the CSF from the intracranial compartment and put it into the peritoneum. Because there's no overlying bone, peritoneum can expand. But brain cannot expand because there's an overlying skull, what we call as ventriculoperitoneal shunt. Right. As I said, we have 2 phases. One, the compensatory phase. Second, the decompensatory phase. Small increments in the brain volume do not immediately raise ICP because of the displacement of the CSF from the cranial cavity into the spinal canal. So when the brain starts increasing, the other 2 components, they try to decrease in their space so that the pressure does not raise. So how does this compensation take place? The CSF in the intracranial compartment goes into the spinal canal, and the falx cerebri and falx cerebelli, they start stretching to accommodate this extra space of the space occupying lesion of the brain. So stretching of the falx cerebri and falx cerebelli with the deformation of the brain. So to some extent they can compensate, but still if there is the space occupying lesion starts increasing, then the compensatory phase goes to the decompensatory phase. So once the above measures, namely the CSF going from the intracranial compartment to the spinal column and the stretching of the falx cerebri and cerebelli with deformation of the brain are exhausted, herniation of the brain tissue from that compartment into an adjacent compartment takes place, what we call it as a decompensatory phase. So obstruction of the CSF outflow, like any stenosis or edema of the cerebral tissue, cerebral edema, or increase in volume from tumor or hematoma may increase the intracranial pressure. So why are we so much concerned about this increase in the intracranial pressure? Because when there's an increased intracranial pressure, two consequences occur. So what are the consequences? When the increased ICP, when the intracranial pressure increases, there are two major deleterious consequences. One, herniation. Because of the increased in the space increased pressure, the brain from one compartment enters into the adjacent compartment, like uncal herniation, tentorial herniation. So herniation occurs. The herniation of brain structures out of their normal location causes crowding and compression in other locations, like an uncal herniation from the supratentorial to the infratentorial compartment, going and compressing the midbrain, especially the third nerve, because of which there's a dilatation of the pupil. So one, there is herniation. Second, because of the increase in the intracranial pressure, it goes and compresses the vessels, so there's a decrease in the cerebral perfusion pressure. So these are the two deleterious consequences of increased intracranial pressure. One, the herniation. Second, the decrease in the cerebral perfusion pressure. So what are the clinical manifestations of common herniation syndromes? One is the central tentorial herniation, when it comes from upwards, downwards and starts compressing the top of the midbrain. Because of the RAS gets compressed, there is impaired consciousness, abnormal respirations, small pupils, decorticate evolving into decerebrate posturing. Decorticate, the lesion is above the red nucleus. So the rubrospinal tract is intact. So initially they have decorticate, but when the hematoma, when the herniation goes beyond the red nucleus and between the red nucleus and the vestibular nucleus, if it gets affected, the rubrospinal tract ceases to function. The vestibulospinal tract now starts functioning and takes over the function, because the rubrospinal tract ceases to function and the function of the vestibulospinal tract is extension. So patient goes into decerebrate posturing. So decorticate, the lesion is above red nucleus. Decerebrate, the lesion is between red nucleus and the vestibular nucleus. Second is the lateral transtentorial herniation or uncal herniation, coming from the temporal lobe, uncus coming from the supratentorial into the infratentorial compartment. Again, there is impaired consciousness because the RA system, reticular activating system, gets affected. There is abnormal respiration depending upon the site. We all know that cerebral cortex produces Cheyne-Stokes breathing, midbrain central neurogenic hyperventilation, Pons apneustic breathing, and medulla oblongata Biot's breathing. So there could be abnormal respirations and unilateral dilated pupil due to third nerve palsy. Because parasympathetic fibers run superficially on the third nerve, when the hematoma goes and compresses the third nerve, the superficially placed parasympathetic fibers get affected. Parasympathetic action is to cause constriction of the pupil. When this gets affected, there is dilatation of the pupil. And corticospinal tract gets affected, there is hemiparesis. Then we have the cerebellar tonsillar herniation, foramen magnum, where there is impaired consciousness, where the cerebellar tonsils go through the foramen magnum and the vital brainstem structures, especially the medulla oblongata, is compressed. So there is impaired consciousness, neck rigidity, opisthotonus, decerebrate rigidity, now the lesions between the red nucleus and the vestibular nucleus, vomiting, bradycardia, irregular respirations and apnea. So hypertension, bradycardia and irregular respiration, they form a triad which is known as Cushing's reflex. which increases the raised ICT. Right, now I'm going to talk about another important concept, the cerebral perfusion pressure. Cerebral perfusion pressure is defined as the mean systemic arterial pressure minus the intracranial pressure, which provides the driving force for circulation across the capillary beds of the brain. So it is the driving force for circulation across the capillary beds of the brain, which is known as the cerebral perfusion pressure. It is the difference between the mean arterial pressure and the intracranial pressure. So normally we would like to maintain the cerebral perfusion pressure above 60 millimeters mercury and intracranial pressure below 15 millimeters mercury. So normally the arterial pressure is higher than the ICP, allowing the brain to be perfused. Now again I'm going to talk about a very important concept, autoregulation. What is this autoregulation? Autoregulation, it refers to the physiologic response whereby cerebral blood flow is regulated via alterations in the cerebrovascular resistance in order to maintain perfusion over wide physiologic changes. If systemic blood pressure drops and the cerebral perfusion decreased, the cerebral perfusion is preserved through vasodilatation of the arterioles in the brain. Likewise, arteriolar vasoconstriction occurs at high systemic pressures to prevent hyperperfusion, resulting in fairly constant perfusion across a wide range of systemic blood pressures. So there could be fluctuations in the blood pressure. Despite the fluctuations in the blood pressure, the cerebral perfusion is maintained at a constant level. This is known as autoregulation. For example, if the systemic blood pressure is increased, there's a chance there could be an increased blood flow to the brain, which could be disastrous. So the brain immediately constricts the vessels so that the perfusion to the brain is decreased. On the contrary, if there's hypoperfusion and there's a decreased perfusion to the brain, arterioles dilate so that it tries to increase the blood flow to the brain. So despite variation in blood pressure, the brain tries to maintain a constant circulation despite variations in the blood pressure. But at the extreme limits of the MAP or CPP, flow becomes directly related to perfusion pressure. So here you can see in this diagram, when the systemic blood pressure falls, the arterioles dilate. So the first one is the normal pressure autoregulation of the cerebral blood flow, and in the second diagram we can see the disrupted autoregulation. So in the first diagram on the left side, see when the systemic blood pressure is decreased, arteriole starts dilating so as to increase the blood flow to the brain. But when the mean arterial pressure starts increasing, the arterioles start decreasing in size so that the less blood is flown to the brain. So this is known as autoregulation. Conditions like head injury may disrupt this auto-regulatory mechanisms, and then the arterioles do not change and the blood flow is not maintained at a constant rate. So when there's an increased blood pressure, there's an increased blood flow to the brain. When there's a decreased blood pressure, there's a decreased blood flow to the brain. So the auto-regulation gets disrupted. So nature maintains a wonderful auto-regulation despite variations in the blood pressure. So this is known as auto-regulation. So this cerebral blood flow is strongly influenced by pH and PaCO2. The cerebral blood flow increases with hypercapnia and acidosis and decreases with hypocapnia and alkalosis because of pH related changes in cerebral vascular resistance. Hyperventilation, this forms the basis for the use of hypertension to lower the ICP, and this effect on ICP is mediated through a decrease in the cerebral blood flow and intracranial blood volume. So when there's hypocapnia, there's a decrease in the intracranial blood volume, and therefore the ICP decreases, because ICP depends on, according to the monro-kellie hypothesis, brain, blood and CSS. So when the blood flow decreased, the ICP also decreases. But when this is only a short-term measure, but when we continue to keep using hyperventilation, there's decreased in the intracranial blood volume so much so that it may result in hypoxemia. So hyperventilation can be used only as a shotgun, only for short term to overcome the crisis, not on a long-term basis. Right. The increased intracranial pressure, Cushing's reflex. So when there's a raised intracranial pressure going and compressing the medulla oblongata and the autonomic centers in the brainstem, the brain tries to increase the blood flow to the brain, increase the blood flow by increasing the blood pressure. So it results in hypertension, bradycardia, and irregular respiration. This is the triad of the Cushing's. So Cushing's response is a reflex increase in arterial blood pressure to maintain cerebral perfusion pressure. Common cause of increased ICP include cerebral edema and increase in the volume of the brain, intracranial space occupying lesion, hydrocephalus, and increase in the volume of CSF. Head injury and stroke can result in a vicious cycle. Elevated intracranial pressure diminishes cerebral perfusion pressure and can lead to tissue ischemia. Ischemia in turn may lead to vasodilatation via autoregulatory mechanisms designed to restore cerebral perfusion. However, vasodilatation and increase in the blood content also increases the cerebral blood volume, which in turn then increases ICP, lowers CPP, and provokes further ischemia. So this is a vicious cycle. So whenever there is a decreased cerebral perfusion pressure, we use vasopressors to increase the blood flow. Right. So what are all the clinical manifestations of increased intracranial pressure? First is the headache. It's a common symptom and is due to the increased ICP, thought to be due to traction on the pain sensitive structures, and tends to be exacerbated by coughing, straining, or changes in posture. It is usually worse at night. Brain by and large has not got any pain receptors. Even if the brain is cut, there's no pain. Even if we cut brain, there is no pain. It is only the meninges and the vessels in the meninges which are having pain sensitive structures and result in headache. So when there's a raised ICP, it is thought that there could be traction on the pain sensitive structures which causes headache. That's why persons who got purely intracerebral hemorrhage like putamen hemorrhage, they don't have headache unless there's a massive edema which goes and causes traction on pain sensitive structures because of the increased ICP, then only it results in headache. So if there's a small hemorrhage, putamenal hemorrhage confined only to the brain, it does not result in headache unless the meninges or vessels on the meninges are affected because of the raised intracranial pressure. Second is a decrease in sensorium. There could be papilledema, sixth nerve palsy, Cushing's reflex, that is hypertension, bradycardia, irregular respiration due to pressure on the autonomic centers in the brainstem. Yeah, now having understood all the important concepts like autoregulation, monro-kellie hypothesis, herniation, cerebral edema, now let's see how to approach a person in ICU, especially the neuro-intensive care and critical care neurology. The essential first task in assessment is to determine whether the cause of dysfunction is related to a diffuse, usually metabolic process like hypoglycemia, hyponatremia, or whether a focal, usually structural process is implicated, like it could be abscess, tumor, or any hemorrhage. So we should know the broad approach in a person who's in critical care, the neurological critical care, the clinical approaches. First to know whether it is a focal cause or a metabolic cause. Focal cause is a structural cause. A metabolic cause is a diffuse process. So what are the differences between these two? So what are the differences between the structural causes like herniation causing coma and metabolic causes, disorders causing coma? Structural disorders usually produce focal sign, like if there's a hematoma or a tumor, it produces focal signs, like it can go and compress the third nerve. There could be pupillary dilatation, so there will be focal signs. But if it's a metabolic disorders like hypoglycemia or hyponatremia, Usually they are generalized signs. And as I said, if it is herniation or structural, it usually goes and affects the parasympathetic of the third nerve and results in pupillary abnormalities if it is structural cause. Whereas metabolic disorders, usually pupils are not affected. Exceptions are drug dose like opiate. And third, the asterixis is not present. But in a drowsy person, in a metabolic coma, it's in a continuum. It is not all of a sudden person does not lose consciousness. Person is conscious, then person slightly become drowsy, then person becomes stuporous, and then finally goes into a comatose state. So it's in a continuum. The decrease in the level of sensorium is in a continuum. And therefore, in a person who is conscious but slowly slips into a drowsy state, but still person is able to obey our commands. So in those persons who are still drowsy but still able to obey our commands, in a drowsy and confused patient, bilateral asterixis is a sign of metabolic encephalopathy or drug intoxication, especially hepatic encephalopathy. You should ask him to extend his hands and dorsiflex abduct and dorsiflex the fingers. So they'll not be able to maintain the posture. It falls, the hands falls, and then they try to correct it. It falls, then they try to correct it. It is presumed to be because of the neurotoxins affecting the posterior column at the level of the parietal lobe, so the position joint sense gets affected. So if the bilateral asterixis is present, it is a sign of metabolic encephalopathy, especially hepatic encephalopathy. And it's a structural cause. Obviously, CT and MRI are usually abnormal, whereas metabolic causes, CT and MRI is normal. In structural cause, blood investigations are usually normal, whereas if it is metabolic causes, blood investigations are usually abnormal. Like hypoglycemia, glucose will be low. Hyponatremia, sodium will be low. So in a neurological disordered person in ICU, the critical care neurology, what are the lab studies and imaging which have to be done? Chemical and toxicologic analysis of blood and urine. It could be hyponatremia, hypoglycemia. So we check out on the glucose, sodium level, or he might have been an alcoholic with low levels of vitamin B1 level. So we have to check out on the alcohol level. It could be lung disorders or cardiopulmonary disorders. So we have to check on the arterial blood gas analysis. We have to take CT scan and MRI to rule out structural causes like extradural hematoma, subdural hematoma, or stroke. Extradural hematoma is because of an arterial bleed. Subdural hematoma is because of a venous bleed. EEG is very helpful, especially in non-convulsive seizures. If a person is throwing seizures and a person is comatose, it is easy to diagnose convulsive seizures. But if a person is not throwing, this person is not having tonic-clonic movements, but still is unconscious, it could be non-convulsive seizures. So clinically, it is very difficult to pick it up. In such cases, EEG is very useful. So EEG is useful to pick up non-convulsive seizures. CJD, there will be periodic waves 1 per second. HSV encephalitis, again there will be sharp waves in the temporal lobes because it goes through the nose. Triphasic waves, the three vectors of the wave, the triphasic waves, very characteristically we see in hepatic encephalopathy. If there's benzodiazepine overdose, there's widespread beta activity. And finally, we have to do CSF analysis because the person who is in a comatose state could be either because of meningitis or encephalitis, where CSF analysis which will help us in a big way. So if a person is in a state of coma, the differential diagnosis of severe brain dysfunction. So almost all states of decreased level of consciousness and coma will fit into one of these three categories. Coma without focal neurologic signs like metabolic and toxic encephalopathies like hypoglycemia. Coma with prominent focal signs like stroke or cerebral hemorrhage. Coma with meningitis syndrome characterized by fever or stiff neck and excess of cells in the spinal fluid like meningitis, encephalitis and subarachnoid hemorrhage. So clinical approach. So person is in a comatose state, is in a very critical state, and there is a raised intracranial pressure. So how are we going to monitor the raised intracranial pressure? Monitoring of intracranial pressure can be an important tool in selected patients like stroke or traumatic brain injury. In general, ventriculostomy is preferable to ICP monitoring devices that are placed in the brain parenchyma because it allows CSF drainage as a method of treatment. But then if there are small ventricles or any risk of coagulopathy, we cannot do ventriculostomy. In those conditions, the ICP monitoring devices that are placed in the brain parenchyma are better. So ventriculostomy or ICP monitoring devices that are placed in the brain parenchyma can pick up the pressure of the brain, the intracranial pressure. The treatment of elevated intracranial pressure. So when there is a elevated intracranial pressure, how are we going to treat? Because the CSF and blood volume can be redistributed initially. CSF can go from the intracranial to the spinal canal. So by the time there's an elevated ICP, by the time elevated ICP occurs, intracranial compliance is severely damaged. So the moment you see increased intracranial pressure, that means the intracranial compliance is already severely impaired. In general, the intracranial pressure should be maintained at less than 20 millimeters of mercury, and cerebral perfusion should be maintained at above 60 millimeters mercury. So there are some disorders which cause elevated ICP, and there are definitive treatment. For example, if the subarachnoid hemorrhage causing hydrocephalus, we can treat by doing ventricular drainage. If there is head trauma and stroke causing cytotoxic edema, we can give mannitol or hypertonic saline. If there's an increased ICP, vasodilatation, worsening ischemia, as I said, the vicious cycle, we give vasopressor agents. The early signs of elevated ICP are drowsiness. A person who is fully conscious slowly slipping into drowsiness, suspect raised intracranial pressure and elevated intracranial pressure. So what we do, we try to elevate the head end of the person. So when there is an head elevation of the head end of the patient, so there's a drainage of the blood, and therefore the intracranial pressure decreases. So early signs of elevated ICP like drowsiness, the treatment is elevation of head. Emergent treatment of raised ICP, hyperventilation, because it causes vasoconstriction and reduced cerebral blood flow, but it is only given for short periods, because if we give for longer periods, there could be hypoxemia because of the vasoconstriction. Ventriculostomy can do where they can directly drain the CSF, or we can give high dose barbiturates. Decompressive hemicraniectomy, we remove the bone so that the brain can expand further. Hypothermia, so that we decrease the metabolism of the brain, and the brain can tolerate the conditions better. So stepwise approach to the treatment of elevated intracranial pressure: insert ICP monitor. Ventriculostomy versus parenchymal device. Ventriculostomy is always better because we can drain the CSF out, but where the ventricles are small or when there's a chance of bleeding tendencies, intraparenchymal devices are better off. The general goals is to maintain the intracranial pressure less than 20 millimeters mercury and cerebral perfusion pressure more than 60 millimeters mercury. For ICP, intracranial pressure more than 20 to 25 millimeters mercury for more than 5 minutes. Elevate the head of the bed, midline head position. Drain CSF via the ventriculostomy if it is in place. Osmotherapy, mannitol, 25 to 100 grams 4th hourly as needed, but maintain serum osmolarity less than 320 milliosmoles per, or hypertonic saline 30 ml, 23.5% sodium chloride we give bolus. So when we give mannitol, it is an osmotic agent. It pulls the fluid from the brain into the intravascular compartment, and the intracranial pressure reduces. You can give glucocorticoids like dexamethasone 4 mg 6th hourly for vasogenic edema from tumor or abscess. Except for these conditions like tumor or abscess which causes vasogenic edema, where dexamethasone steroids are useful. In other conditions it is not useful, like avoid glucocorticoids in head trauma, ischemic or hemorrhagic stroke. So glucocorticoids are primarily useful for tumor and abscess. Sedation, morphine, propofol or midazolam. Add neuromuscular paralysis if necessary. Patient will require endotracheal intubation and mechanical ventilation at this point, if not before. Hyperventilation, as I said, when we ventilate the arterioles, it constricts, and therefore the intracranial pressure reduces, but only to PaCO2 30 to 35 millimeters. Short-term use, because beyond that it causes hypoxemia, or you can skip this step. Pressor therapy, when there is hypoperfusion, hypotension, we can give pressor therapy like dopamine, phenylephrine, norepinephrine to maintain adequate mean arterial pressure, to ensure cerebral perfusion pressure more than 60 millimeters mercury. Maintain euvolemia to minimize deleterious systemic effects of pressors. May adjust target CPP in individual patients based on the auto-regulation status. Consider second tier therapies for refractory elevated ICP, decompressive craniotomy. We can remove a bone flap so that the brain can expand. High dose barbiturate therapy like pentobarbital coma or hypothermia to 33 degrees centigrade. And as I said, primary brain injury, not only primary brain injury, we have to identify and treat the secondary brain insults. Like if the hypotension, if the blood pressure is less than 90 millimeters mercury systemic blood pressure, or hypoxemia, if the saturation is less than 90%, it may lead to secondary brain injury and therefore they have to be avoided. Fever and hyperglycemia, they can also worsen it, the secondary brain insults. So goal is to maintain the glucose level less than 180 milligrams per deciliter by giving insulin. So we have to take care of secondary brain insults like hypotension, hypoxemia, fever and hyperglycemia. So this is a broad approach to a person who is in the ICU, the critical care neurology. This is the book Focused Neurology. I am the medical author, Dr. Sreenivas. The entire neurology, most of the points of the neurology I put in question and answer form. It is available online. This is about critical care neurology, and I've really enjoyed giving this lecture, and I hope you have also enjoyed listening to my lecture. So if you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my web page, Dr. Sreenivas Concepts. Thank you. Bye.